Hello everyone, this is Dr. Sultan Moinuddin Shaukat Ali. I am a radiologist, MD, DNB Radiology, and a gold medalist. So today we have an interesting topic to discuss. We are going to talk on renal ultrasound. So let us start without any delay. Now we'll start with basic considerations. We'll start under what headings we are going to study. So we will study under the seven broad headings. First, we'll see some basic considerations. In this, I'll take you to what probes we use, how do we do the scans. I will also discuss various indications. Then we'll see the ultrasound, a bit of gross anatomy and ultrasound anatomy of kidney. Then we'll discuss the basic techniques what we use, the actual techniques. Then we'll go with the appearance of kidney. We'll see various technical difficulties which we face during our scans. Then we'll discuss some normal variants, which is very important when you are doing the scans. Finally, I will touch upon few pathologies. See, this lecture is not for pathologies. This lecture is meant to discuss the kidney, the normal appearance of kidney, and we will be discussing few normal variants, and I'll touch upon pathologies, and subsequently in other lectures we'll also touch upon each pathology in details. So let us move ahead. Basic thing. So when we are doing ultrasound of kidney, usually we use this probe, which is a convex probe. Okay, this is a convex probe which we usually use. We'll take a laser point. Yeah. So this is, you know, that it's a low frequency, so the depth is high. And whenever you are examining any adult patient for USG abdomen, the first thing you have to do is you have to take KUB protocol in your ultrasound. Second thing is you have to select the probe. So the probe which you will select is your convex probe, okay, which is the abdominal probe. Then sometimes when you have neonate or a child, so you will find that the abdomen is small in size, and in those cases, for better resolution, you will need a linear probe. You know, linear probe, the depth is less, but as far as resolution is concerned, the resolution is far much better than the deep probe. Okay. Next important consideration which you need to keep in your brain is, now look at this. This is called the orientation marker. You commonly call it as eye of the probe. Eye of the probe. So you should know, as soon as you touch the probe, you handle the probe, you should know where does the eye lie. Now, very important, because suppose your probe is placed like this. So this is the eye. So the upper pole of the kidney should be towards the eye of kidney, so that you understand which end is the cranial end, or which is the upper pole, and which one is the lower pole. We'll discuss this in details, don't worry. Yeah. So what are the indications? There are too many indications for which patients come to you for renal ultrasound, but I'll list some important amongst them. So patients with symptoms arising from urinary tract, usually renal colic. So patient come, usually pain in lumbar region, radiating to the groin, patients with renal calculi, patients with hematuria, trauma patients, to rule out renal masses, UTI, abscesses, pyelonephritis, cystic diseases of kidney, acute kidney injury, and very interesting, ultrasound can help us to differentiate acute kidney injury from chronic kidney disease. That is interesting. Now, we'll take you through basics. I'll take you through very fundamental so that you understand things well. Now, this is the basic renal anatomy. Now, you've got two kidneys, one on the right, one on the left, and they are located in the lumbar quadrants, predominantly in the lumbar quadrants. So now you can see that above kidney, you've got adrenal glands. Kidneys are retroperitoneal structures. So very important. You can see here in this image, this is the reflection of peritoneum. Reflection of peritoneum. And you can see this colon. This is ascending colon. This is descending colon. This is the pancreas. And behind that lie the kidney. So this is the kidney. So kidney is in close relationship with colon. Here comes the duodenum, the pancreas, and medially it is related to IVC, aorta, because renal vein drains into IVC. Kidney is supplied by renal artery, which is a direct branch from aorta. So kidney is in relationship with this. So this is one thing which you must know, that kidneys are retroperitoneal. Why is this thing important? Let me explain this thing to you. Why is this important? I'll take a highlight. Okay. So suppose I'm doing ultrasound and suppose I approach kidney from anteriorly. So what is going to happen? Suppose I approach it from here. So ultrasound will pass and here comes the colon. Now you must be aware that USG is enemy of air. USG is enemy of air. Very important. So wherever there is air, ultrasound will not help you out much. Okay. So that makes our concept very easy. If you want to look at kidney, you need to approach from lateral aspects, or you need to approach from posterior aspect. So if you take such an approach, either from lateral aspect, that is from flanks, or from posterior aspect, you will be able to see kidney in a better way. Okay, this part is clear. Now, once this portion becomes clear, now we'll move ahead with various body planes. So this is very basics. Most of you must be knowing, but I'll just revise for you. This is a sagittal body plane. This is frontal or coronal body plane. So I'm cutting it along the core section. This is transverse body plane. So I'm cutting it transverse. Okay. Now I move ahead. Same way you can achieve these sections even in kidney. So you can get sagittal section, you can get coronal section, you can get transverse section. For practical purposes, both sagittal and coronal, we call them as longitudinal section of kidney. Longitudinal sections of kidney. And when you move the probe 90 degree to your longitudinal, you know that all these three axes are at 90 degrees. So you will have to turn your probe to 90 degree so that you get the transverse section of kidneys. So this is how you'll be getting the transverse section. Okay, we'll move ahead. Yeah. So now we'll discuss bit of anatomy portion. So how the kidney appears. Okay. For this, let us start. So basically, human kidney, now you're aware that it is located in the lumbar quadrant. It is retroperitoneal. And now the kidney is surrounded outside by a capsule. This capsule is a tough renal capsule. Now you see that these structures which are you are able to see, these are all renal medulla. So they are called medullary pyramids. And this outer portion which is there, this outer section, this is called cortex. So outside lies the renal cortex, inside lie renal medulla. Each of this, they are renal pyramids. This we know, all of this we are aware of. Now let us move bit ahead. You will see that cortex has got more of vessels within it. Very important. So all those glomeruli, PCT, DCT, they are located within the cortex. And loop of Henle and the various duct-like structures, they are present in the medulla. Now, very interesting, if you see this cortex, it continues inside. Look at this, it is continuing inside, in between the two medullary pyramids. So this portion of cortex which continues in between two medullary pyramids, this is called column of Bertini. This is called column of Bertini. Okay, you remember this, we'll be discussing about this ahead even. Okay, now you see that they open inside minor calyces. Two minor calyces come together to form a major calyx. The major calyx come together to form a renal pelvis. So this is renal pelvis, which then opens up into the ureter. Okay, so renal pelvis then opens up into ureter. Okay, so in kidney you have the main cortex, the medullary region, and then you have got the pelvic calyceal system, which consists of minor calyx, the major calyx, and the ureter. There is at the hilum, this region of the kidney is called hilum. there are three important structures. One is the renal artery, which is entering inside, the renal vein, which is living at the hilum, and the ureter, which comes out of the urinal pelvis. Okay, these are important structures. So this is the basic coronal anatomy of kidney. Now we'll see the same thing on ultrasound. So once you are aware about this anatomy, the ultrasound anatomy becomes easy. So now don't be in a difficulty. We'll make it very simple. So we have taken a section which is a coronal section of the kidney. So can you see this? Look at this carefully. This. So look inside this circle which I have made. So this is your kidney. Okay. Now this is the renal capsule, and this hyperechoic thing which you are able to see outside, this thing, this hyperechoic area. This is the perinephric fat. Perinephric fat. Okay. Anterior renal fascia is also called Girota's fascia. Okay, Girota's fascia. Now I move ahead. Can you see this hypoechoic? What do you mean by echogenicity on ultrasound? It is nothing but how bright those structures are on an ultrasound. That determines the echogenicity. If they are less bright, we'll call them hypoechoic. So now this all structures, these are all hypoechoic renal medullary pyramids. Okay. Now this is the cortex, the outside portion, this is the cortex. Can you see this cortex which is entering in between the two medullary pyramids? Do you remember what is that called? Yeah, column of Bertin. This is called column of Bertin. Now look at this carefully. Can you see this hyperechoic area in between? Yeah, this one. This is renal fat. Okay, renal fat. So this is the fat in the renal sinus, which is normal. This is usually seen. We should not confuse this with some pathology like renal calculi or an abscess. No, this is normal. Okay. Now you know that renal pelvis will open into the. This is the renal pelvis. It should open like that, and then it will go down as ureter. Okay. So I hope that you got some idea about how kidney looks on an ultrasound. So let us move ahead. Let us build our concepts more. So I'll come back. Yeah. So now again, look here, we are scanning the right kidney. We have taken the coronal section. And then can you see this? This is the kidney. Okay. Basically, this is longitudinal section of the kidney, right kidney. So can you see this big organ overlying the kidney? Yeah, this is called liver. And can you see that there is a space between the liver and the kidney? Yeah, this is called Morrison's pouch. Morrison's pouch. Okay, and this is the kidney which is lying down, okay, in the retroperitoneum. Now look ahead, again going ahead, this is the longitudinal scan, the kidney, this is the liver, this is the Morrison's pouch. Again the same kidney, but now look carefully, what have we done? We have turned the probe in the flank exactly 90 degrees. So we have rotated the probe to 90 degrees. So now we are going to get transverse section of the kidney. So this is done to get a transverse section of the kidney. Okay. Now again to simplify the anatomy, now these are all renal medullary pyramids. Outside there lies the cortex. Okay. Then you can see the minor calyces. They turn into major calyx and then they join together to form a renal pelvis. So this is a longitudinal section. Again, this section, this is a transverse section of the human kidney. Okay, on ultrasound. So this is transverse section. Same, this would be outside would be the cortex. Inside there are hypoechoic medulla, and these are all the calyces. This inside bright thing, what you are able to see, this bright is nothing but the fat of the renal sinus. You should not confuse it with stone. Okay, we'll discuss when we discuss stone later on that. But presently you should remember that in kidney there is fat. That fat looks hyperechoic. It's bright. Okay. So now when you come to left kidney, the major difference is that left kidney might be slightly lower as compared to right kidney because of, right kidney is pushed down by the liver which is present. And second thing is the organ adjoining left kidney is your spleen. So you can see that this organ which is spleen and this is the left kidney. Okay, the parts and everything remain the same. Now this is an interesting image. Let me tell you what this is. Now this is an ultrasound of a neonate. So you can see that this is the liver, this is the kidney, okay, and then can you see this? These are the medullary pyramids. These are the medullary pyramids. And now there is a organ, or there is a structure which lie above this kidney, right kidney. This is nothing but the adrenal gland. So in routine scans, if you see an adult patient, you won't be able to see the adrenal gland. They are usually not seen. But in neonates, we can see adrenal glands. Now we'll discuss what is the technique of position. We'll discuss the various technique of ultrasound, and at the same time, I'll also tell you about the positions. So you can put patients in supine position, or you can try D-cube position. Okay. Now the major difficulty which you have in this scan is that in locating kidney, as I told you, that there will be a lot of bowel loops anteriorly, and you will have to search kidney. Okay. So you will have to apply a lateral approach or a posterior approach to view kidneys. Okay. So you can put patient in supine position or in D-cube position or even prone position. In fact, prone position will be very easy because you will locate kidney more easily because it is retroperitoneal. Okay. Or you can sometimes use a combination of this position to optimize your view. Moreover, you can ask the patient to raise their hands, and secondly, you can also ask the patient to take deep breath. Okay, so that once the patient takes deep breath, the kidney comes down, and then you can visualize the kidney in a better way. Now, basic approach, so you can use an intercostal approach or a subcostal approach, or you can view it from posterior aspect. Now, let us see the technique of ultrasound. So, firstly, we are seeing it for the left kidney. Okay, so this is the leg frank region. We have placed the probe. We are trying to take longitudinal section. Now, if I go a bit back, yeah, see, look here, the gain part is very less. So now I have got kidney. You're able to see this is the kidney, this is the spleen, and now what we do is we try to maximize gain. So I've increased the gain, and now you're able to see that the gain is more, and you're able to see kidney nicely. So this is left kidney, and above the organ is spleen. Correct. And now we have freezed it so that we can take the length. Can you see this? This is nothing but the renal pelvis. Okay, this is the renal pelvis. This region is the echogenic fat. Okay, this is the hyperechoic fat. The outside region is the cortex, and then in between you can see the hypoechoic renal medullary pyramids. Okay, now superior to that, this organ which has been highlighted is the spleen. Okay, so now we examine again. You see this is the hyperechoic fat surrounding kidney. This is perinephric fat, and very important, you have to sweep through it. Just one section is not sufficient. You can see that how I'm sweeping through it. Okay, so you have to sweep. Similarly, now you have to take calipers, and now this is the upper pole of kidney, this is the lower pole, and between them you have to measure from upper pole to the lower pole. You have to take the largest longitudinal length which you get. Okay, in the longitudinal section, you cannot take length in oblique sections, or else you will get false readings. Okay, now we have turned the probe. Now see, look at this, look carefully how we have done. We have turned the probe to 90 degrees. See, this again I'm showing you, we have turned the probe to 90 degrees. Now we are seeing kidney, and now this is the transverse section. Now we are sweeping it. Just we won't stay there constant, we'll sweep through that, and we are sweeping it, and then we are able to see the renal this outside is the renal cortex, the echogenic fat, and similarly we also would be looking for the right kidney. So now we'll be seeing for the right kidney. Patient is supine. Now we are placing the probe in the right flank region. I'm able to see the right kidney here, and now look carefully. Outside is the cortex. This is the liver. We are able to see this portion is the cortex. Okay, so renal cortex is outside, renal pelvis, this is the echogenic fat, and then this hypoechoic structures are the renal medulla, and then you can see that liver which is overlying that, kidney which is overlying the muscles. This is called psoas muscle. Sometimes you can ask the patient to raise the arm or take a deep breath when you are not getting the views in a better way. Now we have turned the probe to 90 degrees, and you can see that we have got the transverse section, and now you can view the cortex is outside, the echogenic renal fat, and this is how you have to scan through the kidney. You have to sweep through it so that you don't miss any pathology. Remember, in ultrasound, this is a key method that you scan through, you sweep through an organ at least in two views. Any pathology you see, if you see a cyst or a mass, anything, you need to see it in longe and then take a perpendicular view so that you get a view in both the sections. And this also helps to avoid and know whether that thing which you have seen is actually a pathology or just an artifact. Okay. Now, the next we are going to see is the renal size, echogenicity, CMD, margins, and pelvic calcium system. So, whenever you see kidney, we have to describe it under 5 headings: size, echogenicity, CMD, margins of kidney, and the pelvic calcium system. Okay. Now, Let us go ahead. Size, basic. So, like we discussed, size is measured from upper pole to the lower pole, and this is the longitudinal section of the kidney. Okay. At the same time, we have to take the breadth and we have to take the width. Okay. And then we'll be reporting it as right kidney measuring approx 9 by 4 by 3 centimeters in size. Okay. And then there can be a discrepancy in size between the two kidneys. Sometimes you might find that the left kidney is slightly larger than the right kidney. It can happen. But whenever the discrepancy is more than 2 centimeters, this is abnormal. Then you should look for something. Then you should look for some abnormality, especially renal artery stenosis or something of that sort. Okay. Now, at the same time, when both the kidney size are small, so when do you call small kidney? When they are less than 8 centimeter in adults. Okay, then it is called chronic kidney disease. Okay, so in CKD, the size of kidney is less. At the same time, in patients with acute kidney injury, in patients with pyelonephritis, in diabetic patients, you will find that the size of kidney is larger than usual. Now, I'll discuss few technical errors which we get. Especially, suppose you have not taken a longitudinal section in a better way. In this case, you have got a partially longitudinal section or oblique section, and hence you won't get the craniocaudal length in a correct manner. So, very important, when taking length, you need to focus both upper as well as lower pole in your screen to get a exact measurement. Similarly, sometimes, now look at this scan. We want to examine this kidney, but the depth is improper. We don't want all these gases to be there. Okay, so you have to keep it at the proper depth. So once you have, so very important, you need a proper depth, you need proper gain, and if you do not put proper gain or proper depth, you won't be able to interpret it correctly. Now we come to the next important point, which is echogenicity. Now, after size, renal echogenicity is an important factor. Now look at this. Kidney is less echogenic as compared to liver as well as spleen. This is a very important statement. Okay, kidneys echogenicity is less as compared to liver as well as compared to spleen. Now the liver has a variable echogenicity. You will find that in Indian population you've got a lot of fatty liver patients. So I personally and most of the radiologists, they rely on echogenicity of spleen. So if renal echogenicity becomes more than the spleen echogenicity, it is absolutely abnormal. Okay, that cannot happen. That should not happen actually. So if you see kidney, you see that it is less echogenic than the liver. Here is the left kidney, this is the spleen, and you can see that this left kidney is less echogenic than the spleen. So that is normal. Okay. At the same time, I mentioned an extra point that liver is less echogenic as compared to pancreas, and pancreas is less echogenic as compared to retroperitoneal fat. So renal, now there is one exception to this. In neonates, you will find that the renal cortex is normally hyperechoic. So you look at this image, this is the renal cortex, which is almost appearing to that. So it is isoechoic to that of the liver, but that is normal. So in neonates, the hyperechoic cortex may persist for 3 to 4 months. After 4 months, it normalizes to that of adults. Now, I'll show you one pathological image so that you understand. So now, in this case, you see this is liver and this is the right kidney. And look at this carefully, the echogenicity of the cortex. It is more echoic as compared to that of liver. So when the echogenicity of the cortex is more as compared to that of liver, in other words, I say the cortex is hyperechoic as compared to liver. So this is a case of medical renal disease. Okay. Same in this, I've tried to show the hyperechoic cortex in the same case. So now so first we have seen is the size, second we saw was the echogenicity. Third thing to be seen is the CMD. What is CMD? Corticomedullary differentiation. So if you see the renal parenchyma, it consists of cortex and medulla. And you know that these are the renal medullary pyramids, which we have already seen. And so we should see on ultrasound whether we can differentiate between the cortex and medulla. So here you can see you can clearly differentiate between the cortex and medulla on a linear probe, and similarly on convex probe also you can differentiate between the two. Okay, and if this differentiation is lost, then you should remember that that is a marker of chronic kidney disease, CKD. Okay, sometimes the differentiation between renal cortex and medulla might be accentuated, that might increase. That happens in cases of AKI, acute kidney injury. Now we'll discuss. Now look at this kidney. Now can you see? Now we can't see the medulla here. The corticomedullary differentiation is completely lost. Okay, and even I cannot be able, I'm not able to differentiate between the liver and the kidney. And this is a completely hyperechoic kidney with loss of CMD. This is a marker of chronic kidney disease, CKD. Now we move to the last part of kidney when we observe it. The last part is the pelvic calyceal system. So normally we don't see the pelvic calyceal system unless it is dilated. So in this case, can you see the dilated calyces and then the pelvis which is opening into the ureter? So pelvic calyceal system is seen when the system is dilated, and of course if the system is dilated, it means you need to look for some obstruction which should be there either in the ureter or in the bladder or urethra, anywhere. Then that becomes a different topic. We need to search for the obstruction. Now, few variants I would like to discuss. There is a variant which is called extrarenal pelvis. So here, suppose this is kidney, the pelvis would lie outside. This is natural. So this is called extrarenal pelvis. So in cases of extrarenal pelvis, how will you differentiate whether there is actual hydronephrosis? So you will find that the calyces are not dilated. When the calyces are not dilated, that is extrarenal pelvis, and that is not hydronephrosis. Okay. Next important thing is the margin. Now this is kidney, this is normal kidney. Can you see the margin? They are smooth. They are smooth. But look at this case. Now you can see that the margins are irregular, and this is called cortical scarring. What does the cortical scarring indicate? It means the patient is having hypertension, or it also means that the patient might have had previous urinary infection. Okay, that can also lead to cortical scarring. Even vesico-ureteric reflux can lead to cortical scarring in long-standing cases with recurrent infections. Okay, so V-shaped scar usually indicates hypertension, and U-shaped scar usually indicates renal infective pathology. Now we discuss certain normal variants. One of them is malrotation, persistent fetal lobulation, parenchymal junctional defects, hypertrophied column of Bertin, and dromedary hump. So we'll discuss malrotated kidneys. So normally, if you see kidneys are like that. So the hilum should point medially. Hilum should point medially. But now look at this case. Look at this case. This is the liver, and this is kidney. So you see the hilum is pointing upwards towards the liver. That means this is a malrotated kidney. Now in this case, look at this kidney. You can see that there are lobulations. Lobulations. Okay, and interesting thing, how will you differentiate whether these are fetal lobulations or this is chronic kidney scarring? So you have to see if these lobulations are corresponding with the column of Bertin. If lobulations correspond with the column of Bertin, that means that it is persistent fetal lobulation and not renal scarring. Important. Now, sometimes you might get such junctional defect. This is a normal anatomical variant. It marks the union of two ranunculi located at the, and then usually if you see the location, it is at the junction of upper 1/3 and lower 2/3. One interesting variant is hypertrophied column of Bertin. So when you say hypertrophied column of Bertin, you have this is the hypertrophied column which is pushing the vessels and the sinuses at superiorly as well as inferiorly, and very interesting, it is seen more commonly on the left side than on the right, and it is more commonly in the interpolar region, that is between the right and the left pole, and it is commonly mistaken for mass lesions, and so you have to differentiate it from masses. It is usually continuous with the cortex and it is usually not very large, not more than 2 centimeters. Now, one interesting thing which you get on ultrasound of kidney is dromedary hump, and you have to differentiate it from renal mass. So can you see this? This is a hump over here. This is called dromedary hump. But how will you differentiate whether it's a mass or not? So you have to look at the thickness of the kidney throughout. So if you see the thickness at the upper pole and thickness in the mass region, that is dromedary hump region, you will find that the thickness is uniform. But in this case, if you see, this is the region of dromedary hump. This is the region of the mass, and you see this thickness, and the thickness over here is not same. In fact, the thickness over here is more. That means this is not a case of dromedary hump. This is a case of renal mass, whereas this is a case of dromedary hump. So this upper is a case of dromedary hump, and inferiorly this case represents the renal mass, exophytic renal mass. Now, few pathologies, just I'll enumerate them. So can you say this? This is called renal cyst. On ultrasound, if you see, this is the upper pole, this is the lower pole. You can see an anechoic, well-defined, round, cystic structure, and it is exophytic in nature. And there is no solid components, there are no septa. This is how simple renal cysts look. In details, we'll see it later on in subsequent lectures. Now, this is how simple renal cysts appear. Now look at this case. Here you see multiple well-defined, variably sized anechoic cysts throughout the right kidney. So it has filled the kidney throughout, and they are variably sized. Some are big, some are large, some are too small. So this is a case of polycystic kidney disease. So autosomal dominant polycystic kidney disease, or ADPKD. Now, this is the kidney, and can you see this hyperechoic structures here? These are hyperechoic area, foci, and they are showing interesting. This is called posterior acoustic shadowing. So these are nothing but renal calculi. Similarly, can you see the kidney over here? There is a lower pole renal calculi, and you can see here in this kidney, the region of pelvis, you have got a calculi here. Okay, so this, and it is showing posterior acoustic shadowing. So this is a case of renal calculi. Again, this is kidney, and then this is liver, and then can you see a flare of fluid in between them? So this is a marker of perinephric fluid. This fluid is anechoic, very important. In cases of trauma, if you get such fluid, this is the region of Morrison's pouch, and that becomes an indicator of hemoperitoneum in cases of trauma. Now, very interesting, this case, can you see that this is kidney? Pelvic calyceal system is dilated, and there are few moving echoes. So that represents not just hydronephrosis, there is pyelonephrosis. Along with that, if you see kidney, look at the outermost surface. The fat over here in the perinephric region is very much hyper. So bulky kidney with perinephric hyperechoic fat with moving echoes within the pelvic calyceal system. That means pyelonephritis with pyelonephrosis. So to summarize as a whole, USG is one of the very important tool which helps in ruling out various renal pathologies and helps to screen the renal pathologies. Most importantly, we can differentiate medical renal disease, that is AKI, CKD, versus surgical pathologies, that is renal calculi or stones or masses, which we shall discuss later on in details. In renal ultrasound, basic thing is that four important things are most important. They are to be looked for. There is the size of kidney, the echogenicity, the CMD, that is corticomedullary differentiation, and PCS, which is the pelvic calyceal system. Thank you.